Hi, welcome to the International Interprofessional Mentorship meeting. I am Dr. Kate Barlow, the founder and host for today's meeting. It's May 24th, 2022, and today Dr. Anna Brussa is here to talk about the IRM model. Please mute yourselves during the presentation and hold all questions until the end. In order to receive a certificate of attendance, please complete the survey link in the chat box that I will post in just a minute, and you will need to remain on the webinar until the presenter is finished. At the conclusion of the presentation, we will have an optional meet and greet that you're welcome to attend. So thank you all for coming today, and let's get started. Anna, thank you so much for joining us.
Hi, thank you guys for having me here. I'm so excited. As Dr. Barlow said, my name is Anna Brussa, and I've been a pediatric occupational therapist for over 20 years now. And I've had the pleasure of working in a variety of settings. So like outpatient pediatrics, acute care pediatrics, the neonatal and pediatric intensive care units, and more recently, pediatric home health. So I currently work at a pediatric home health agency in Austin, Texas, where I serve as the lead occupational therapist and the director of quality assurance performance improvement. In 2021, I obtained my post-professional OTD, woohoo, at Boston University. And the focus of my doctoral project was reframing communication as an active ingredient in our therapy interventions so that we can build stronger collaborative relationships with the parents and caregivers of our pediatric clients. And it is through this work that I came to find the intentional relationship model, which I have come to know as my OT love language. And so I'm so excited to be here today and share my knowledge of this model with you all. So the intentional relationship model, or the IRM, is a model of practice that was developed by Dr. Renee Taylor, a clinical psychologist. The IRM examines how the therapeutic use of self influences the client-practitioner therapeutic relationship and client participation in therapy. So it proposes that stronger client-practitioner relationships occur when we as practitioners are able to actively apply both our clinical knowledge and skills as well as our interpersonal knowledge and skills together in our clinical practice. And so it aims to answer the question, how can we intentionally apply our therapeutic use of self to facilitate positive client outcomes through participation in occupation? The IRM is a mediational model of practice. So this means that it's meant to enhance our other therapeutic interventions. So like sensory integration therapy, feeding therapy, cognitive rehabilitation therapy. And so it's meant to be implemented alongside these interventions to facilitate client participation and progress. And so here on this slide, you will find the 10 core principles of the intentional relationship model. I will not be reviewing each of them one by one during this presentation, but I wanted you to have them here available for reference. However, I will be touching on these principles within the content of this presentation, and I hope that as we go through this talk together, you will be able to identify these principles, how they are interrelated, and how they can be applied in our daily practice. And so just to start off, I'd like to ask a question. I'd like to know a little bit about what you all think of the therapeutic use of self. And so when you hear therapeutic use of self, what does that mean to you? It's okay if you guys want to be quiet. Just thought I'd throw it out there. And so if you ever have the chance to read The Intentional Relationship by Dr. Renee Taylor, she goes through the history and the evolution of the definition of the therapeutic use of self. One definition that tends to stick out to me is kind of that the therapeutic use of self is the planned use of our personalities, insights, perceptions, and judgments as part of the therapeutic process. And so when we as clinicians enact our therapeutic use of self, we incorporate planned strategies for how we choose to communicate with our clients and their families. And so one thing we need to start to get to know a little bit is like, what does the therapeutic use of self require of us? And so if we're going to enact our therapeutic use of self, our OT superpower with intention, it really kind of requires us to be aware of our behaviors and to be able to manage and have self-control over just different aspects of who we are as individuals. And one aspect that we need to kind of grow in our management and self-control is in our physical selves. And that can include our physical presentation, so how we choose to present ourselves professionally when we're working with clients and families. It also is the physical environment. And so that can be how we choose to present our clinic, our therapy room, our therapeutic materials, how neat and safe we keep our therapeutic space. The therapeutic use of self also requires us to have behavioral self-control. And this is that self-management of our facial expressions, our body language, our use of touch, and how we behave during our therapeutic interventions when doing activities with clients. It also requires emotional self-control. And this is more of our self-control during communication on that emotional plane. And so what is our body doing? What is our face doing? How is our voice being reflected while we're communicating with our patients and their families? The therapeutic use of self also requires psychological self-control. And this is how we take care of ourselves, right? This is how we know if a client is really draining us, if we're starting to feel like we need a break. It's very important that we take that break, our knowledge of taking care of ourselves to prevent burnout as well as compassion or caregiver fatigue. And then it requires interpersonal self-control. And this is our reactions and responses to the client's behaviors or emotions during therapy communication. And so as we grow in our therapeutic use of self, it's important that we grow in our awareness of how we communicate. So in other words, growing our interpersonal base. When we grow our interpersonal base, we will not only be better equipped to tailor our communication to best meet our clients' needs, but we will also be more equipped to take care of both of our clients as well as ourselves during the more intense therapy situations that we tend to encounter. And so then, how do we grow as intentional communicators, right? And when we're communicating intentionally, we're not communicating as a rote part of our practice or in response to a random question our client might ask, but rather communication is something that we plan for, just like we plan for our therapy activities, so that what we are communicating and how we're communicating it best meets the needs of our clients and their families. So how can we as practitioners grow as intentional communicators? Well, one way is to practice critical self-reflection. And this can involve taking a real look at ourselves, right? And becoming more aware of what are our communication strengths. What are the areas of growth? Where do we struggle when we're communicating with clients and families? How do we react and communicate under stress, right? Under those stressful therapy situations. And how is that different from how we communicate when things are going really well? And so it's really getting to know who we are as verbal, nonverbal, and emotional communicators, as well as who we are as listeners. Another way to grow is to practice interpersonal discipline. And this is where those self-controls kind of that we just talked about tend to come into play. So it's that self-management of who we are as individuals. And so this can include growing our awareness of therapy situations that might trigger us on that interpersonal or emotional level. Because when we're feeling stressed on those levels, it really clouds our ability to be able to communicate objectively and intentionally with our patients and or colleagues or friends or family, right? It can also include asking parents for feedback and then being able to take in that feedback from our patients in a way that is calm and objective, remembering that the client defines the successful relationship. And so when we get feedback that can be constructive, it's important that we just take it in and use it as a learning experience, right? Keep ourselves self-control and use it as a learning experience to get to know who our client is and what their needs are. Another way to grow as an intentional communicator is by practicing mindful empathy. And this is being able to objectively see and understand a patient's feelings and reactions from their perspective, and to do so without judgment. It also includes balancing the activity aspect of therapy with the interpersonal aspect of therapy and kind of keeping them in the forefront, both in the forefront of our therapy. Activity is what we do, and interpersonal is how we feel. So, for example, if I'm working with a parent and I'm supporting them in their ability to feed their premature baby, and this baby has a history of being disorganized as a feeder, gags frequently in the past, has had a tendency to stop breathing, and is at risk for aspiration, that activity can come with a lot of feelings and a lot of past lived experiences. And so when I change the activity to support this family's success, it's important that I also check in with them and how they felt both during the activity as well as after the activity is over. And finally, growing in our cultural humility. This is a learning approach to working with people of diverse backgrounds and to recognizing the power dynamics that exist in healthcare. A patient's communication characteristics and needs may be influenced by their culture and their life experiences. And so it's important that we grow our awareness of our own cognitive biases and of any power dynamics that may be present in the therapeutic relationship so that we can communicate with mindful empathy. And so the IRM does offer a set of concrete communication skills that we can use to help us navigate our clients and their families and their interpersonal characteristics, as well as those intense therapy situations. And to help us navigate through some of our strategies, we're going to work with John for a little bit. So we as clinicians have been working with John for about 3 months. He is a 20-year-old young man who sustained a traumatic brain injury about 3 years ago, and he's hoping to get a job at his local supermarket. So John has come to occupational therapy for help building his resume, applying for jobs, and conducting a job interview. So far, you and John, you guys have really hit it off. You have a very positive working relationship. During therapy sessions, though, you've started to notice that John has a really hard time remaining calm and regulated during the interview process. He tends to become visibly frustrated and anxious and loud when he's asked an unexpected question. So you present the idea of reviewing calming strategies that John can use during the interview to help him regulate his feelings and answer those unexpected questions. John, he kind of sighs and he states, gosh, I'm just so tired of trying to stay calm. This is just too much to think about. So now take a moment and think, how would you feel most comfortable responding? Would you, one, ask John what strategies he feels would be helpful and be willing to include them into the therapy? Two, ask John questions to better understand his perspective on the interview and then summarize your understanding from his perspective. Three, tell John that many people feel this way when looking for a job and connect him with a local support group. Four, educate John on the benefits of calming strategies and how using them could really help him through the interview process. Five, emphasize the progress John has made so far during interviews and let him know you are confident he will continue to improve. Or six, with John, make a list and analyze the positive and negative aspects to using calming strategies to help with the interviews. So take a moment and just jot down on a random piece of paper or hold on into your head the number that you feel most comfortable responding. Okay, so everyone got their number? All right, so we're going to move into modes of communication. And the IRM defines a mode of communication as a specific way of communicating with clients and their families. And the mode or modes of communication that we use most often, those help to define our therapeutic style. The IRM has identified 6 modes of communication, and these are collaborating mode, empathizing mode, encouraging, problem-solving mode, instructing mode, and advocating mode. Modes of communication are subjective and they're perceived differently depending on the person and the situation. So enacting the same mode of communication in 2 similar situations with 2 different people may have 2 very different results. But it's important to remember that no one mode is better than the other. Each mode of communication has the potential to strengthen the therapeutic relationship. During communication, though, we must be mindful to, 1, not overuse any one mode when interacting with patients. We need to be mindful of our timing. So when we choose to enact a specific mode to meet the patient's interpersonal needs at that time. And of course, whether or not the mode of communication we have chosen in that moment best matches the patient's needs. And if it doesn't, then a mode change on our part may be needed. And so collaborating mode is when we intentionally involve the patient in all aspects of therapy. So like goal setting, which treatment activities we're going to be doing, discharge readiness. It's a mode that really emphasizes client empowerment. And what's really great about collaborating mode is that it really promotes client choice. And so it could work really well with patients who are well-informed and proactive in their therapy. It could also help build confidence through autonomy and empower those patients that need to feel like they have a little bit more control over their therapeutic process. Things to be mindful of is that it may not work well with patients who really view the clinician as the expert, and it may not be understood as well by patients of cultures that really emphasize a hierarchical structure. Empathizing mode. This mode demonstrates understanding from the patient's personal experience. And we gain this understanding by asking deeper questions. And we do this without judgment. What's really great about empathizing mode is that as the patient is telling us their story and giving us that deeper understanding through their own words, it provides opportunity for them to self-reflect on their own process and experience. It's also a really helpful mode in helping resolve conflicts and misunderstandings, and it could really help de-escalate emotional situations. Things to be mindful of, though, is that it can be a very emotionally heavy mode for some people. It could also slow down the pace of therapy, and it can result in the patient really becoming overly dependent on the clinician to meet their interpersonal needs. We have encouraging mode, and this mode is really fun. This is when we cheer our patients and their families on. It relays hope and it really boosts the opportunity for patients to explore in their participation in the therapy process. It really brings in a positive energy because this is when we celebrate effort and success, and it can really bring out the playfulness of therapy. Things to be mindful of here is that if we use it too often, patients may stop responding to our encouragement. And if used again too often, it can possibly delay the development of that intrinsic motivation that we like to see patients and families develop over time. Problem-solving mode is when we use reason and logic to promote a wider understanding or an alternate perspective. And we do this through the use of strategic questioning. It's a mode that really engages the intellect, and so it might work well for patients who are very verbal and analytical or who may be uncomfortable with emotions. Things to be mindful here is that if used maybe at not the right time or too often, it can almost be seen as too strategic. And it's a mode that really relies on a lot of structure. And so it can neglect other interpersonal needs within the therapeutic relationship. We have instructing mode. This is when we use our teaching style and approach to provide our patients with education. And what's really great about instructing mode is that it promotes the transfer of learning and it empowers patients through the sharing of information and constructive feedback. Things to be mindful here, though, is that sometimes we can fall into over instruction, and that can bring out frustration in both the client and in ourselves as clinicians. And it can be viewed by some individuals as authoritarian, and so it can bring out some power struggles with patients or individuals who are a little bit more sensitive or possibly oppositional in nature. And then we have advocating mode. This is the mode that relates the patient's experience and disability to a larger context. And so it really promotes the client's awareness of the occupational and social injustices that may be present, and it provides them with the resources that they may need to remove those contextual barriers and enhance participation in occupation. Things to be mindful here is that sometimes as clinicians, we can get excited and overestimate a patient's readiness or drive for a certain level of independence or change. Also, patients may not be emotionally ready to take on those bigger issues, and they might need a little bit more time to discover those barriers and injustices for themselves. So now if we go back to John in our scenario, let's see, which mode did you respond with? Did you respond with 1, collaborating mode, 2, empathizing mode, 3, advocating mode, 4, instructing mode, 5, encouraging mode, or 6, problem solving mode? Does anybody want to share? Did anything pop out or surprise you in your response?
A couple people are
Thanks, Bobby.
mentioning in the chat box, encouraging and 3 and 5.
Okay. All right, 3 and 5. Awesome. Great. Thank you for sharing. So as you move forward in your practice, start reflecting and thinking about what modes you tend to use the most often. What are your main go-to modes? These can be where you live, where you're most comfortable, your strength modes. And those can be really helpful to draw from when you encounter a stressful therapy situation. Also begin to think, what are the modes that maybe you don't use very often? Or is there a mode that you possibly don't use at all? These help identify your areas of growth, right? Where we as clinicians may need to stretch and practice and grow in our therapeutic use of self. Because the more modes we're able to truly enact, it really helps to build our therapeutic use of self toolbox. And it enhances the wider variety of situations and clients that we may respond to in a way that they view as therapeutic. Also remember that when we use a mode of communication, we should be mindful to use it with our whole selves, right? So it's not just what we say or how we say it, but it's also our body language and our facial expression. Remembering that it's our nonverbal expression that tends to stay with our patients and families long after our session is over. And so communication, it's not just our verbal and nonverbal communication, but it's also who we are as listeners. Listening is one of the primary ways that we gather information. And when we listen empathetically, we listen in a way that supports a deeper understanding of the patient's experience, and it validates their experience without bias. And one way that we can let our clients know that we've been listening empathetically is to use what is called a summary statement. A summary statement is a brief statement that reflects on the main points of what is being communicated. So it's not repeating what the patient has said word for word, or adding to what the patient has said, or trying to figure out what the patient might say next. Using a summary statement helps us confirm that what we heard is what the patient is trying to tell us from their perspective. And so we all encounter barriers when trying to listen to our patients, right? So, for example, as a pediatric clinician, if I'm pressed for time and I'm running late and I have to get this evaluation done today, I might be trying to clinically observe and jot down notes of the child as he's bouncing around the room while the parents are telling me their medical history and their therapy concerns and the journey that brought them to occupational therapy today. And while that's a really efficient use of my time, from the perspective of the patient, I may not be looking like I'm listening, right? Empathetically or even effectively, right? And so then, what are some barriers that you all feel that you encounter when you're trying to listen to your clients?
Distracted.
Yes, distractions. Absolutely. Thank you. And so, common barriers to listening empathetically or from the perspective of the patient, right, can include distractions, those wandering thoughts. Thank you so much. It could also include jumping in to help patients finish their thoughts. Sometimes, again, time is a huge moderator, right? And our ability to really be able to sit down and communicate with patients and families. And so, or we might feel uncomfortable in those prolonged silences, right? So we might jump in to help the patient finish their thought. And while we're doing it to be helpful and to move our therapy along, from we may not be capturing what they're trying to say from their perspective, right? It could also include planning what you're going to say next while the patient is talking. That's one that I've fallen guilty to in the past, and I've worked really hard over time to overcome and kind of catch myself when I'm doing it so I can nip it, right? It could include comparing the patient's experience to a personal experience or to someone else's in an effort to normalize it, or judging or analyzing what the patient is sharing in order to help to figure out, like, is this true? Um, those can help. Those can all be barriers to us listening from the perspective of the patient. And so as we move forward in practice, it can be really helpful to become aware of those barriers that we encounter, because when we're mindful of them and we're able to catch them while they're happening, then we could start to actively work on them so that we can listen more empathetically. So now that we've touched a little bit on who we are as communicators, we're going to move into getting to know our clients, because part of our job as we strengthen our communication and grow that interpersonal base is to get to know our clients and their preferred communication modes. And we could do this by getting to know their interpersonal characteristics, which the IRM defines as the emotions, behaviors, and reactions that patients express during therapy communication. Interpersonal characteristics can be enduring or they can be situational. Enduring interpersonal characteristics, those are those typical everyday emotions, behaviors, and responses. That's how our patients respond consistently across therapy sessions. And it's really important to take note of those, because those typical everyday responses can really guide us on how to best communicate and match our communication modes to the patient's communications needs on a typical everyday basis, right? Then we have the situational interpersonal characteristics. Those are those atypical emotions, behaviors, and responses. The ones that kind of make us pause and go, okay, Mrs. Smith doesn't usually respond this way. I wonder what's going on. So if you're going there, if you're thinking there might be a situation happening where the interpersonal characteristics and therefore needs of this patient are going to change. And situational interpersonal characteristics are typically the result of a contextual circumstance. So like maybe a loss in the family, a move where the patient has lost their emotional or social support system. They're in a new environment. They're not quite sure what's happening. A global pandemic. These are all things that might cause a change in how people react or behave or respond to therapy situations. And so it's also important that we take note when our patients exhibit a situational interpersonal characteristic, because what that tells us is that those typical modes of communication that match their needs on a typical basis, those may not be the best modes right now during this time. And so we may need to shift or actively change how we're communicating in our sessions to meet the patient's interpersonal needs while they're going through their situational circumstance. And so the IRM does delineate 14 interpersonal characteristics that we could see in our clients. And these include things like general communication style, a client's tone of voice or body language, how they respond to a challenge in therapy, how they respond to a change in the therapy routine, how they give you feedback, right? How they receive feedback, how much touch or tactile intervention they want or tolerate. So these are the little characteristics that we can start to take note of so we can shift and change how we're communicating to kind of meet their needs. Culture, while not an interpersonal characteristic in and of itself, it's important to consider because we need to consider all of these interpersonal characteristics within the context of the patient's culture and how that intersects with who the person is as an individual and their individual interpersonal needs. And so, of course, despite our best efforts and good intentions, there are times when things don't go as expected in our therapy sessions. And the IRM refers to these as interpersonal events. An interpersonal event is the therapy communication activity or reaction situation that may result in an emotional response from the patient. And how we negotiate or work through an interpersonal event can either strengthen or weaken the therapeutic relationship. What's important to know is that interpersonal events are inevitable. They happen. And so the IRM does describe in detail the 12 most common interpersonal events practitioners tend to encounter in therapy. And these can include expressions of strong emotions, or an activity or task that all of a sudden brings up a big emotion, resistance or reluctance to participate, nonverbal cues, or those like verbal under the breath comments or jabs that clients might say to just kind of tell us they're not buying what we're selling today, testing boundaries. So it's important that we intentionally grow our awareness of these events so that we can identify them while they're happening and then learn to respond to them using our intentional communication. And so how we work through an event, what we do is we bring in our interpersonal reasoning. And the IRM defines interpersonal reasoning as the decision-making process we use during communication to best meet a patient's interpersonal needs. Using an interpersonal reasoning process can really help us to stay objective, cope, and intentionally respond to those stressful therapy events in a way that the client perceives to be as therapeutic. Examples of non-therapeutic responses to a stressful event include like responding defensively, so you're trying to defend your point of view or why you did what you did, talking over someone or interrupting someone to get your point of view across, responding with anxiety, a comparison to another person, or responding with judgment. These may all be perceived as non-therapeutic by the patient. When we use our interpersonal reasoning, it's really helpful to draw from our knowledge of our strengths, right? Who we are as communicators, where we really shine, our knowledge of the patient's interpersonal needs and characteristics, and our growing mindful awareness of the interpersonal aspect of therapy. And so the intentional relationship model does have a 6-step interpersonal reasoning process that we could use to help us navigate these interpersonal events. The first step is anticipate, right? And this can include anticipating what therapy situations, tasks, or conversations may result in interpersonal stress before they happen. So for example, if I have a patient that I'm working with and the mom is just always like, oh, Anna, you're just wonderful. I love OT. My child is going to need OT forever. You're going to always come, right? You're always coming. We're never getting rid of OT. And it comes time that the child is ready for discharge. I can anticipate that a conversation surrounding discharge with that parent may result in some interpersonal stress. And so I can start to plan for it ahead of time intentionally, right? It could also include anticipating what may happen the next time we see a patient or a family after an interpersonal event has occurred. I don't know what it is, but sometimes these just pop up at the end, right? We're having a pretty good session, and then all of a sudden it's time to transition out of therapy and something happens or a feeling comes out or an activity just falls apart and it's the end and we don't have time in our work to kind of handle that event at that time, right? We don't always have it. And so sometimes it's like, okay, next time I see this patient, I'm feeling really stressed. What am I going to do? Well, I can anticipate that I'm going to, address the interpersonal event, and I can start to plan for it ahead of time. And as we really grow our interpersonal base and really bring our knowledge of the interpersonal aspect of therapy forward, it can include anticipating what may happen next while an interpersonal event is happening. Step 2 is identify and cope. So when an event happens, take a second before responding. Pause and label the event. Give it a name. When we can give it a name and identify it, we can have some knowledge and power over it, right? We're like, okay, I know what's happening. I know I kind of can start planning what I'm going to do. And if you're unsure of what's going on, observe the client. What is their perspective or their perception of what is happening right now? Because seeing the event from the perspective of the client can really help us identify what may be going on. And once we feel like we've kind of identified it, don't forget to cope. It's so important. Take a deep breath. Remember, interpersonal events are inevitable. They happen even though we have the best intentions. And so even if it happened because of something you said or maybe something you did, remember to give yourself some grace. Consider that another patient on another day may have had a totally different reaction to the same thing. Step 3, determine if a mode shift is required. So this is when you think, okay, what communication mode am I currently using? How well in my experience, does this communication mode work in an event like this? And what communication mode may work better? And then based on your thought process there, you choose a response mode. And when choosing a response mode of communication, we consider the client's communication preferences and how this event might impact the relationship, right? So if I respond this way, how might that impact how we come out the other side? Step 5, so we've chosen a mode. Now we draw from the relevant interpersonal skills associated with that mode. And when we do that, we consider what are my personal strengths in this mode? What are my areas of growth in this mode? What are my overall communication skills? What are my past experiences in using this mode when managing a similar situation? And what do I know of my patient? What do I know of their characteristics and their needs? And then after we've responded, we gather feedback. And this is a step that I feel we don't do as often as we should. I don't know if it's just kind of like, oh, that's done. Whew, or if we kind of are a little bit intimidated to ask because it's just been really stressful and things have calmed down. What will happen if I ask for feedback? But it's important because that's where we grow and really get to know our patient a little bit more. And so it could be just observing the patient, right? How do they look different now? What is their body language telling you? How they feel? Like, have they re-engaged? And then we could check in with the patient, and ask for feedback, how they feel about the event and our response, and if there's anything else they would like to discuss. And if a patient continues to feel that an event is unresolved, the best we can do is see if the patient will continue to share their perspective, validate their experience, and then acknowledge if our response was not the best one. There you go. All right. So we're going to come back to John. So this part is a little interactive if people want to chime in as we move forward. That is most welcome. So back to John, our 20-year-old patient. We've been working with him for 3 months. He had a traumatic brain injury about 3 years ago, and he really wants to work at his local supermarket. And so far, we've hit it off. We have a positive therapeutic relationship. But we've noticed during sessions that John's been having a hard time remaining calm and regulated during the interview. He gets very frustrated and anxious and loud when he's asked an unexpected question. And so you present the idea of reviewing calming strategies that he could use during the interview to maybe help him stay calm and answer those unexpected questions. John sighs and looks away. He's like, I'm tired of trying to stay calm. It's just too much to think about. So in this scenario, we're going to say the clinician responded with, educate John about the benefits of calming strategies and how using them could really help him in his interview process. John sighs again, his voice is growing louder and he's getting angry and he's like, you just don't get it. It's too hard to do this. There's too much. I just can't. And he turns away, he stares out the window, he's ignoring your presence. Now, if you've been practicing as long as me, you've certainly been ignored by a patient at least once or twice. But right now we're just kind of like, oh no, oh my gosh, I've lost John. What do I do? What do I do? How do I bring him back? What do I do? Stressful, right? So we use our interpersonal reasoning process and we kind of use it to help us work through this event, right? So if we think, step 1, what could have anticipated this response?
I would say one thing that I always think is interesting is really trying to listen. Like he's already said that he's angry, but as clinicians, sometimes we just want to keep going. Like we have a plan and we're like, no, I know better than you that these strategies are going to help you. But if you don't acknowledge I'm already angry and frustrated, like I think we have to stop and anticipate that he's not in the right frame of mind to hear about strategies, that we need to deal with the anger and the frustration first. So, which, as a clinician, we kind of want to keep going, right? But if you do, that's what happens. Then they can't hear what you're saying and they don't really buy into the plan.
Thank you. Thank you so much for sharing. You're right. I mean, you've touched on a lot of things that, there was a lot of nonverbal and nonverbal cues and verbal innuendos happening there, right? And so you're absolutely right. We are crunched for time and we have our mission. So we could have anticipated those little signs could have helped us anticipate that an interpersonal event was possibly coming, right? Thank you. So step 2, identify and cope. So let's label the event, and we don't have to use IRM language, right? Let's just give it a name. So what event has occurred? What do people think?
In the chat box, it says John is frustrated.
Yes, yes, thank you. Yes, so John, yeah, so he's having an expression of strong emotion, right? If we're or maybe it's the interview process. Maybe it's that task that comes with a lot of emotions for him, right? If you know about the IRM too, one may even say that because he's turned away, he's now ignoring you, that there's been a little bit of an empathetic break in the relationship, right? Like we've missed a lot of those cues, and now he's kind of just shut down and turned away. And so we really have to tread carefully here and just kind of repair this relationship, right? And so, but then before we decide what we're going to do, we're going to cope. So we're going to take a deep breath. We're going to say, I had good intentions in trying to educate John about these calming strategies. A different patient may have done okay with that, but it wasn't the right step for John. Okay, so let's see, what are we going to do? So what mode was the clinician in when they responded to John? Okay.
Encouraging is in the chat.
Okay, so maybe it all depends, right? How they were educating, but they were providing John with education. So typically when we as clinicians provide education to patients, we're in instructing mode. We're kind of using our teaching style and our approach to kind of teach and instruct. So if we're educating John about calming strategies and why they would be helpful, we're enacting an instruction kind of mode. And so how well do we think instruction mode, and then we think, okay, so I'm in instruction mode, or the clinician is in instruction mode. How well does that mode work in a situation like this? Well, I kind of tried it and he's kind of gotten really upset, right? So maybe it's time I shift and I choose a different response mode. What mode do you all think might be helpful to responding to John? Okay, I opened the chat. I see problem solving, collaborating mode, encouraging mode. Great. Yeah, so remember, modes are subjective, right? So there's no one right answer. It's just important when we think, okay, this is a stressful therapy event. John is visibly frustrated and upset. He's turned away from me. How do we help him re-engage? What mode do I choose, right? So maybe John doesn't like feelings and emotions, right? Maybe we've learned that about John. And so we're going to do problem solving mode, right? And so maybe John feels like he needs to have more control. So we'll bring him back by asking, okay, John, well, what do you think? What strategy, how do you think what would be helpful for you while working through this interview process? So for the purpose of this exercise, let's just say we're going to use problem solving mode because 2 people answered that one. So we'll go with it. So we choose a response mode. We're going to say, I feel that problem solving mode is a good mode to respond with here, right? Then we draw from the relevant interpersonal skills associated with that mode. So what might we do if we're going to enact problem solving mode? So if we remember, problem solving mode is the mode that really brings in verbal and logic, right? And so if we're going to resolve a conflict using problem solving mode, we have to be mindful of our strategic questions. And so we might ask questions that may help John kind of re-engage on that intellect level, right? The intentional relationship model also has what's called a mode sequence, and that's when we can choose to when we can intentionally choose to put two modes not together at the same time, because you have to use each one fully and separately. But what you could do is you could say, okay, I'm going to start with problem solving mode to gain a better understanding and resolve this conflict. But then I'm going to move into collaborating mode to plan for the next session. So you could intentionally do that. Someone wrote, maybe take a logical approach and identify the problem specifically through discussion and then come up with strategies. Exactly. And so for that answer, thank you, Kathy. So that would be enacting problem solving mode first. And then once we've identified the problem with John specifically, we would shift to collaborating mode and come up with strategies together for next session, right? And then step 6, we gather feedback, right? So we take a look at John. Is he still ignoring us by the window, or has he kind of shifted his body back? Is he now looking at us? Has he engaged in the conversation? These would all be nonverbal feedback from John that we've kind of navigated this interpersonal event in a way that he perceives to be as therapeutic. We might even ask him, and then don't forget to self-assess. Ask yourself, how do you feel about the event, right? How do you feel about how it was resolved? And then given the feedback we get from John, right, and our own consideration of the event, we can start to lay down the groundwork from what can be done differently in a similar situation in the future. And that's how we grow our interpersonal base. And so key takeaways is, I hope as we move forward today, I believe that interpersonal growth is like a lifelong skill, right? You can never reach the top. And just when you think you're doing really great, a patient comes along that just kind of really challenge you to grow in new ways, right? So always get to know yourself as an intentional communicator. What are your main go-to modes? What modes do we need to stretch and grow and practice in? Right? Start using those summary statements and see if we're really understanding what patients are trying to tell us from their perspective. And then intentionally observe and take note of your clients' interpersonal communication characteristics and start using those to guide your communication. Remember, interpersonal events are inevitable and they happen to everyone. We're humans working with humans, often under times of change in their lives. So remember that they're inevitable and grow in the awareness to identify them, because once we can identify them, then we can cope and navigate them using the interpersonal reasoning process. And so here are the references I used for today, as well as some links to some resources on the intentional relationship model. And then questions.
This was great. I know that there was one question in the chat and I asked if they could hold off. Bunface, did you want to ask that question that you had in the chat? I'll go ahead and read. It says, case scenario of a nurse attending outpatient occupational therapy clinic working as an ICU nurse in the same facility who suffered stroke 6 months ago. She is accompanied by her husband and her parents during therapy. She is overly emotional when instructed to carry out a task, and she starts crying. When trying to encourage her, she even cries more. Her husband has been greatly affected, and he is really concerned. Would you want to comment about this and the best way to go about it? Thank you.
Okay, so thank you. This is great because this is the stuff that we see every day, and it is stressful and hard. And so she is an ICU nurse, right? So that tells us that she's used to a fast-paced. I'm assuming, I don't know her, right? But let's say she's used to a fast-paced environment, thinking on her feet. She's educated, knowledgeable. She had a stroke 6 months ago, and she's going to therapy at the same facility where she works, which can be hard, right? And she's very emotional, right? So we think at that interpersonal reasoning process, right? You can anticipate now that when she comes to therapy, things are going to be emotional, right? And so it's really to start thinking, and I don't know how you've laid out the therapy sessions, but we can anticipate a lot of emotion and a strong emotions, a lot of crying. And when you've used encouraging mode, so you've tried that, it exacerbates a little bit of that emotion. And her husband's greatly affected, is really concerned. Okay, so one thing that you could start to think is, okay, so if we're really emotional, and we tend to grow more emotional, do we need to add a little bit of structure, and ground the experience a little bit? And so sometimes this is when, in the intentional relationship model, they say you could try, and then emotional when instructed. So problem solving mode would be one that would provide a lot of structure and would help kind of take away some of the emotion. I have to be honest, though, that's my weakest mode. I'm an empath. And so I'm like, there's a self-assessment of modes out there, by the way, you all should know. It's available on the IRM website that I have on the references, and it's super interesting and fun to take. And it's free. They've recently done their whole website, and now they've started charging for a lot of stuff at the IRM clearinghouse that they used to not to. But the self-assessment of modes is still free. So you could take it and it kind of tells you your modes, right? And so you can go 2 ways and see what happens. You could try empathizing and asking deeper questions. Like, I see that you get very upset when you come to therapy. Can you tell me more about that? And that's an open question I tend to ask, because it just opens floodgates sometimes. Because what is making her emotional? Is it that she's coming to therapy where she used to work and she feels bad now because she can't do what she used to do? Is there trauma from the stroke? Like, what is happening? And so asking that deeper question and just letting her express why she's really emotional can be helpful. And then you knowing what next steps to do. So is collaborating mode great, because then she could have some more control, so then you could decide, well, would you like to do this or this today? And kind of see if she can have some more control over the tasks that she chooses to take on. Maybe she sees them as too hard and they need to be graded down, but we won't know until we really ask her. And so that's how I would sequence that, because my strength mode is empathy. My weakest mode is problem solving. So that's what I'm always trying to grow in.
Thank you. Bonface said thank you. A very noisy environment. So
Yeah.
Thank you for that. We have another question out of Uganda. Patients is wondering, I know it's a model and related to client-therapist relationship, but what about communication with the multidisciplinary team? Can you incorporate the IRM there?
Yes. And so, but that's a newer application of the model, right? And in the resources, there is an OT practice article. Can everyone get OT practice? Do you know? No,
You have to be
I
a
have
member.
it. Oh, can I share the article if I have it?
If someone individually emails you for educational purposes, you can share it with an individual. I think that's how that
so
works.
People can email me. I have the article. You may not be able to get CEUs, but you could read it, right? It's one of their CEU articles, but you could read it. And one thing that Dr. Popova proposed was a broader application of the intentional relationship model, where you can incorporate it with your team, your boss, or at an organizational level. And that blew my mind, because I loved that concept. Because sometimes when you're looking for a place to work, or you're looking, for an experience to grow your practice, I feel that you have to kind of know yourself as a communicator, and then see if that the culture of that environment is a good fit for you, right? But you can definitely apply it. And in fact, her whole expansion of this model is to really relate it to preventing burnout and creating resilience. And so I would say, yes, you can definitely incorporate it. And what's really interesting in communication research as a whole, because I read a bunch of it, is that when people learn and really start using models of communication, so like solution-focused coaching, you know, or the IRM, clinicians report automatically applying those same strategies to like their personal relationships or to other relationships outside of work. So I would say, yes, you definitely can.
Great. All right. Well, it is time. There's a couple more comments in the chat box. And thank you so much, Anna, for this amazing presentation. I really appreciate it. If anyone has any questions after today, please feel free to email me and I will forward them to Anna. Again, thank you. Everyone is welcome to stay for the optional meet and greets.